Hi everyone, we are going to talk about Unit 1 in the SUMO course of study for CASAL 1. This is talking about patient health history and physical assessment. The first part of this unit, you are asked to read Chapter 10 in your DMECO Health and Physical Assessment and Nursing text. That chapter is available to you in My Nursing Lab in the course contents. So if you are looking for that, that's where that's located. One of the most important things that we do as a nurse over and over and over again throughout our entire care process for a patient is communication. It's one of the first topics we talk about in Intro to Nursing, and it's one of the most congruent topics and topics that runs through every facet of nursing. Our patients, when they come to us, are often vulnerable, stressed, and it's really up to us to gain rapport and trust of the patient. And one of the best ways we do that is really by active listening. There's a number of things that we can do to make it apparent that we're actively listening to the patient. First of which is attending. You want to sit facing the patient. You want to appear calm, not rushed, not distracted. Typically, as nurses, we have a full patient load at all times, and we often are rushed and distracted. But it's important not to let the patient know that. If you feel rushed or distracted, you can't give your patient the proper time. Maybe it's time to go delegate a smaller task elsewhere to someone else that's proper, so that you can sit down and focus on the patient, give them the time they need in order to gather the health history information and do a proper interview with the patient. Another aspect of active listening is paraphrasing. Just verifying what the patient said, making sure that what they've tried to convey to you is what you've received. Direct leading, giving the patient a specific direction in which you'd like them to speak about something. A good example right here is, let's discuss your medications. It gives the patient a topic that they should, elaborate on and make sure that you have covered that topic. Focusing, just focusing on one aspect of what the patient said, asking them to go over it again, and making sure that you're not missing anything. Sometimes things are very complicated. Sometimes patients will tell you a number of things quickly. They might not know what's pertinent to the problem and what's not. So when you as the nurse get flagged for one of those important pieces of information, you can focus in on it and make sure that you are asking them to repeat it, make sure that you are getting the information you need. Questioning is just what it says, asking the patient questions, particularly about what they're feeling, can give you an idea of a direction in which you need to go further in your interview. Reflecting is somewhat similar to paraphrasing, where you're reflecting back what the patient says they're feeling like. Summarizing is reviewing basically everything that you've talked about with the patient. Some of the barriers to active listening are listed here. You've got false reassurance, where you are reassuring someone blindly or falsely about something that maybe you can't quite do that. One of the biggest pet peeves of mine is, people saying, "Oh, it's all going to be okay. It's all going to be okay." Guess what? It's not always going to be okay. Patients know that. Sometimes patients come in, they have a bad feeling. The last thing they want is a nurse telling them, "Oh, you're going to be fine. There's nothing wrong. You're going to be fine." Sometimes you don't know that. And sometimes if you do give false reassurance, what happens is you don't gain the trust of the patient, or you lose the trust of the patient. So you can be empathetic and supportive and offer words of encouragement without being falsely reassured. Another thing is interrupting or changing the subject. If you interrupt someone when they're speaking, it just makes you feel like someone is not interested and not listening to what you said, or that you don't feel it's important to focus in on. Another thing is passing judgment. The second you make a patient feel like you passed judgment on them, they're going to shut down. They're not going to want to talk to you. You're not going to gain the necessary information to elicit, pertinent things that you need to make a good nursing diagnosis. Cross-examination, making someone feel like they're in trouble, like they're on trial, hammering them with pointed questions can make them feel intimidated, can make them feel small, and does not help you get the information that you need. Technical terms, that's something I've struggled with my whole career, is using too many technical terms when dealing with someone who doesn't understand them. We tend to use a lot of medical terminology, and if we do so, we need to clarify what it means. Medical terminology is kind of like another language, and when we speak another language to someone, they don't understand us. So using technical terms is not good in many ways, but a lot of times if you're using too many technical terms, patients or patients' families don't even know when to ask questions. The old saying, you don't know what you don't know, that is very true in this type of situation. And so it's really important to use lay terms. And if you do have to use a big word or a technical term with medical jargon, you need to clarify what it means. Discussing sensitive issues. There are certain topics for people that are particularly sensitive. Sometimes you don't know that certain things are sensitive to people until you broach those topics with the patient. If you have the sense that patients getting squirmy or that you've made them uncomfortable, really be sensitive on that topic and give them some time to open up to you, if it is in fact pertinent to the health history information. Things that will enhance the active listening process are positive regard, gaining rapport with the patient, gaining their trust, showing empathy. You can be empathetic to someone, showing them support, and that you can be sincerely sorry for their situation if it needs be, without having been in their shoes. Being genuine. People know when you're faking. People know when you're full of crap. So be genuine. Don't offer words that you don't mean. Being concrete. Concreteness is a great enhancer to active listening. So when you can be concrete about something, follow through. If you tell a patient that you'll be back in 10 minutes with their pain medication, make sure you're back in 10 minutes with their pain medication. It may not be important or as important to you, but to the patient, they're sitting there watching that clock. So be concrete when you can, and don't be concrete when you can't. Follow through. And most importantly, be really forgiving of patients and their families. Typically when we see them, they are in a very stressful situation. They had surgery, they have an illness, they have a death, whatever it might be. It's an extremely stressful and potentially vulnerable time in their life. And they might not be their most chipper or friendly self. So just be forgiving of that and don't take that to heart. So a health history is a very comprehensive record of a patient's past and current health history. It's gathered during the initial interview. As we see the patients, we update it as things change. Or we update it and write that there are no changes. And we also have to emphasize that the most important aspect, once again, is effective two-way communication. The health history interview is based on different sources of information. A primary source comes from the client themselves, the patient. Secondary sources of information are going to be a spouse, a friend, a family member who's there who's also offering information, or a record that provides additional information about the client, maybe from another healthcare provider. There's also different phases of the health assessment interview. Phase 1 is the pre-interaction phase, which is the time in which you're gathering information before you've met with the client. Data from the medical record any previous health risk assessments, health screenings, any therapy records, dietitian records, any other healthcare professional and their records, their documentation that you have access to is going to be part of the pre-interaction, the phase 1 of the health assessment interview. This helps to streamline the information gathering process. Phase 2 is the initial interview. This is where you have that planned meeting where a nurse is gathering information about the patient. Typically, we start this off by having the patient use a health history form and filling that out. Most hospitals will ask you to fill one out if you're coming in to have surgery. If you're visiting with a physician for the first time, you fill out a detailed health history form, and then the nurse goes over that and verifies the information on the form for you. Phase 3 is the focused interview. It's used throughout the physical assessment, during treatment, and while caring for the patient. So the focused interview is going to be when you are talking and asking the patient questions during treatment, while you're doing their physical assessment, honing in on one topic or another, or a body system, and asking questions directly to the patient. So some of the subjective pieces of information that you're going to get during the health history interview are going to be things like the biographical data, where they live, their address, what their current health or illness is, any past medical history, significant family history, psychosocial history, and then a review of body systems. And the objective information is information you're going to get from a basic physical assessment. The objective information, remember, is going to be things that we can inspect, we can palpate, we can percuss, or we can hear. These are things that pieces of information we gain through our assessment. This is taken right from your D'Amico book. This shows the table that talks about the health history and the format of the health history. It shows you the different types of information which fall into those categories, and things that are really pertinent. Physical assessment, if you go back to this screenshot, this is from Unit 1 in your SUMO course of study. We just talked about Unit 1.1, which is the patient health history. 1.2 is going to be that skills module in ATI on physical assessment, and 1.3 is the head-to-toe physical assessment. This is where you begin to incorporate the hands-on skills and the skills checklist that we use, and those are the skills that you are going to utilize in your learning labs, which is where I like to say the didactic content that you've learned and the hands-on skills kind of mesh together, where it all kind of comes together. For your physical assessment, here's a snapshot of 1.3. These are where your skills checklists are that you're going to be going over and reviewing, getting to know really well for your learning lab. I definitely recommend, you have to print them off, but print them off and get to know them well, because the better you get to know them before you go to learning lab, the more time you're going to have to focus on the physical actions that accompany these skill sets. Because once again, it's the didactic meeting the hands-on, and they come together. So if you can take care of one part of that process before you get there, it's going to help. So physical assessment instructions, and these are right from your course of study. Some of the things that you're going to be doing: assembling your equipment, making sure your hands are washed or hand hygiene's followed. You're going to greet and identify yourself to the patient. You want to also identify the patient themselves, make sure you're dealing with the right patient. One of the things too you can't underemphasize is when you are greeting the patient, you are checking their orientation. There's a lot of things that we do immediately as we're walking into a room to meet with a patient where we're eliciting information. When I walk into a room and I say, "Hey, Mr. Jones, how you doing? My name's Lisa, I'm going to be your nurse today." Well, if Mr. Jones is staring off into space and not acknowledging his name or not looking over at me, I can immediately tell there's a problem with his orientation. I might not know how deep that problem goes yet, but I can tell you that if he's not deaf, if he can hear, and he doesn't respond to his name, then that's a problem. If he responds to his name but he's confused and says, "Nurse, why do I need a nurse?" Well, then you know he knows he's Mr. Jones, but he's confused as to where he is. So you can see that just walking into the room, talking to the patient for just a split second, you're already beginning to assess them. One of the other things you're going to do right after you introduce yourself and you've made sure that you've got the right patient and greeted them, you want to explain what you're going to do. Patients are almost always okay with the task that we need to carry out if we educate them prior to. If we tell, Mr. Jones that you have to palpate for his bladder or whatever it is, or, listen to his heart and lungs, check the swelling in his feet, whatever it is that you're going to do, explain to him so he's not surprised, so he doesn't get freaked out when you reach for him. If your hands are freezing, tell him your hands are freezing first. You want to provide for privacy wherever you can. When we do head-to-toe physical assessment, there are times when we are assessing sensitive parts of a patient's body. That does not mean that we can't provide for privacy on other parts of their body, though. So you just have to be very cognizant of how you're going about your physical assessment, and that we are providing privacy wherever we don't immediately need to be assessing. You always want to start with the 5 vital signs: temperature, pulse or heart rate, blood pressure, respiration rate, and pain. Those are things that we check for immediately. And it takes, very little time. Pain is something that we assess often in the hospital and consistently. We assess when we round on them. If we give them medication, we also have to come back and reassess to make sure the medication helped. So that's one of the things that while you're doing their blood pressure, "Hey, Mr. Jones, I'm Lisa. I'm going to be your nurse today. How you feeling? I'm going to go ahead and, is it okay if I do your vital signs really quick, Mr. Jones?" While you're doing their blood pressure, while you're putting the cuff on them, you could be asking, "Mr. Jones, on a scale of 1 to 10, or 0 to 10, 10 being the worst pain you've ever felt, what's your pain right now?" You've just assessed his pain while you're doing his blood pressure. You can count his respiration rate while you're doing his blood pressure or checking his pulse or listening to his heart, whatever it is. You can do multiple things at once, and as a student nurse, that's kind of a foreign concept, but these are some of the few things that you're going to be doing right in the beginning, right away. You're going to ask how the patient feels. You're going to look around the room. Is the room neat? Are there hazards? If the patient has a Foley, is the Foley in a position where they won't trip if they try to get out of bed? Is there an IV pole on the ground that they could trip over? Are the side rails up? You're really checking the environment to make sure that it's clean and that safety hazards are eliminated as much as possible. And then as you assess the body systems, you want to also observe for non-verbal cues. If you're asking Mr. Jones how he feels and he says, "I feel like crap," and you do his vital signs, you check him over, you do a head-to-toe physical assessment, you, in the process of that, are going to want to look for cues. See if there's anything in particular that you can elicit or that you can observe, which will clue you into definitive things that the patient's experiencing. Pain is something that sometimes, a lot of times people will occasionally downplay. "Oh no, I'm okay, but they're grimacing or they're sweating, their blood pressure might be high, or they tense up or jump off the bed when you palpate their stomach, if they've had surgery or something." Just watching for those nonverbal cues so that you can hopefully clue into their needs. A lot of times patients don't want to bother you with problems or pain, and so you just have to be aware of it to make sure that we are doing what we can to make them comfortable. You're going to be looking for mobility and range of motion. Is the patient really stiff when they try to move up in bed? When you ambulate them or stand them at the side of the bed, does it take them 15 minutes to get to the side? Were they able to get up and move around no problem? Their head's fine, no dizziness. Just being aware of these things. And in the process of helping the patient and doing them with the patient, you really can assess a lot about their mobility and how well they're moving. This is the physical assessment checklist that's in your SUMO course of study. It talks about how you are going to go about doing your physical assessment. I'm not going to go into great detail about this because you'll learn about this in your learning lab, and you'll also combine this with all the information that you're getting from the individual checklists. But this kind of gives you an idea of, the order in which you are assessing things. It's a little bit out of order. Generally, you're washing your hands before you enter a room, or just after you enter the room. Go over to the sink, wash your hands, use the hand sanitizer. Whatever the facility policy is that you are in, you always wash your hands before patient contact. You ask some general questions. Hey, how you doing today, Mr. Jones? How was your night? Did you get any sleep? And in that process, when you begin talking to them, once again, like I said earlier, we're assessing their level of consciousness and how oriented they are. Are they able to tell us why they're there? Why are they at the hospital? Do they understand who they are? Do they understand what time of day it is? Or are they a little bit confused just because they've been sleeping for a few days? Or are they drastically confused? They don't know their name. They don't know that they're in a hospital. Those are all things that you begin to assess immediately as well. You next go into the head, eyes, ears, nose, and throat, and the neural part of the physical assessment. You're going to check the head, the eyes, ears, the nose, throat, and then the neuro assessment. Follow your checklist, but you typically are checking, reflexes, deep tendon reflexes, grips, equality of motion on both sides. And that kind of depends on why the patient's in the hospital and how depth you go, but the neuro part is one of the next things that you do. Skin, you want to note any breaks in the skin, if they have any scars or major lesions, any wounds. You want to look for color, temperature, and hydration, and also turgor to tell if they are dehydrated or not. The thoracic region, you're listening to lung and heart sounds. You're listening for their character, their quality. You want to listen for both the appropriate sounds being there and then the inappropriate sounds not being there. You're going to palpate the chest wall and breasts for any lumps or tenderness. The abdomen, we listen to bowel sounds. You always listen for bowel sounds in at least 4 quadrants for at least 1 minute. We can't say that someone has hypoactive or absent bowel sounds unless we have assessed for a whole minute. You can palpate for tenderness or lumps. You'll be palpating the bladder. You'll talk about the intake and output of the bowels and bladder. Ask about appetite. You also assess the genitalia for tenderness, lumps, or lesions. Extremities, you're looking for temperature, cap refill, and range of motion. You're going to palpate for pulses, and while you're doing the palpation for pulses, you're noting any edema that you find. And that's the overall physical assessment. I really recommend, I can't emphasize it enough, going over those checklists and becoming extremely familiar with those individual checklists so that you are ready for your learning lab and that you can put all these physical skills into play when you get to learning lab. If you do have questions, specific questions about any part of the assessments, why we do things the way we do, or if you have a lab question, you can always email me the lab questions. Often I have to turn over to Allison Stoll, who's our director for that. but I'm certainly happy to point you in a direction if I can't answer your question. But let me know how we can help, and I will talk to you all soon. Good luck getting to know your checklist.